Welcome, my name is Isaiah Ailes. I am a recent medical school graduate. In today's video, I'll be providing an overview of CT abdominal imaging with emphasis on key information for medical students for their clinical rotations and boarding exams. As a forewarning, the information provided in this video is intended for medical students and healthcare professionals. It is not intended as a substitute for professional medical advice, diagnosis, or treatment. The cases we'll be looking at are found for free publicly on Radiopaedia, so thank you to all the contributors who uploaded cases. So we'll first start with the normal anatomy. So this is a coronal view. Let's just go all the way to the top here. All right, so we're gonna start from the very anterior aspect of a patient. So in CT abdominal imaging, just like a CT chest and pretty much any other CT image really, the patient's gonna be laying supine more often, 99% of the time. Rare occasions they are not. But in this case, we were looking at the most anterior aspect, and you can see the abdominal muscles here. This is the soft tissue window, so we can best see everything here. And let's get into a little bit more into the abdominal cavity. So first thing you'll notice is the liver here. It's very impressive in its size generally. It stands out. It's in the right upper quadrant, of course. And then you'll see next to it is the stomach. And the stomach, you'll see, has its rugae as well. And you can see that inside there, it gives it its unique appearance. You'll also notice that there are gastric contents, which is pretty common to see, but you typically don't see air as in you would in the bowels here. So focusing on the stomach here, you can see where it comes in and where it goes through the diaphragm as well, which is important to take notice, as oftentimes there will be a sliding or some type of hernia. And then while we're here, you can see the liver has its hepatic veins, and you'll see in this contrast study with IV contrast, you can see the organs very well. We'll see a few examples perhaps where they don't have IV contrast, and it's a bit hard to make out the difference in the organs. Although, yes, it's possible, it just makes it a bit more challenging. And you'll see here the left upper quadrant, we have the spleen and the splenic vasculature coming from the splenic hilum there. And then you'll see the pancreas tail. It's this lumpy appearance here, and it goes all the way from the middle to about right upper gastric area, right upper quadrant area. And of course, this is the epigastric area that we're seeing the pancreas. And then, so we'll scroll back so we can see the stomach here. Let's go, keep going, and then we'll see with the stomach where it transitions to the duodenum. And then the duodenum, of course, will go to the rest of the small bowel. For radiologists, they will follow and trace all the bowel. To save everyone the pain, we will not be doing that because it is a bit tedious to scroll through all the bowel and make sure everything is okay. And you'd be looking for any malignancies in terms of any neoplasms or any type of other swelling or mucosal thickening. Those are some signs that clue you in to focus your eye in a particular area. And for medical students, of course, it's just nice to be able to identify the structures. Of course, know the type of window that you're looking at, know the type of slice that you're looking at in terms of the view, if it's a coronal, axial, sagittal. And then if you can pinpoint some of the other structures, that's great. And mostly what you're looking for is just knowing the normal anatomy. That's most important. And so let's focus back on the liver again. We can see the gallbladder coming here, that little structure. Sometimes it's absent, right? So just keep that in mind if you don't see it. And then, when we start from the stomach, of course, you can see the small bowel from there. But sometimes it's also easier to start with the rectum and then start all the way up from the large bowel and then trace that out and go from there as well. And you can see there's actually some fecal matter within the large bowel, and that's entirely normal as well. And you can see sometimes there will be air. Again, when we eat or drink or anything like that, we can consume air. Again, perfectly normal. And sometimes when it's too excessive, that's when you know it's an issue. So that goes the descending colon, and then it'll go from the transverse colon. And then you'll have to keep sliding around and just, you can visualize. I don't want to keep moving around and make you dizzy here. But let's look at the ascending colon here. And this is another important feature. I'm going to switch it over to the non-labeled because I think it's easier to look at. Other one's a little busy. But for the ascending colon here, you can actually see the cecum. And this is very important because this is where you can identify where the ileum comes in and joins the large bowel. But most importantly as well is you can identify the appendix. So if you're ever looking for the appendix, identify the ascending colon, go all the way down to where it first starts, the most proximal end, and then try to look for a little tube that comes off of it. In this case, this is the appendix here. Comes all the way up and then comes all the way over. And then you can tell it's the appendix because it just ends in a blind loop as well. And sometimes it's difficult to see depending on the orientation of all the anatomy, but nonetheless, you can try to find it. Don't be upset if you can't find it. Sometimes it is difficult, or maybe even surgically absent. Make sure you check the patient's history. So otherwise, you can see here the vasculature, so the portal vein, and then we'll have the SMV coming off of that as well. And then, so the superior mesenteric vein, and then we have the inferior mesenteric vein, and then the splenic vein going through the spleen. Again, if you can identify that, that's fine, but for medical students, again, just appreciating the image is most important. Another aspect of the anatomy you do want to appreciate here are the kidneys, right? You can see the kidneys very bright, and this is characteristic of IV contrast, making the kidneys enhanced here. And so you can see the renal cortex is the outer area versus the hypodense, or the darker region, or hypoattenuating, rather synonymous terms used in radiology, are the actual renal medullae. And you can see these are the calyces, where urine collects, and then it all drains into the major calyx, into the renal pelvis. And that'll come all the way down and give you the ureter, and you can trace that down if you wanted to. And then otherwise, while we're here, you can appreciate the left-sided structure here is the aorta, abdominal aorta, and it comes into the common iliac arteries. And you can trace all those down, and perhaps you can appreciate the divisions of internal, external. But otherwise, you can see the inferior vena cava as well, and it'll give you the same idea. And this patient, it's very easy to appreciate. Sometimes it is a bit more difficult. And that is pretty much all there is in terms of the abdominal cavity. You can see here all this black is part of the mesentery, which is important because it's the fatty tissue within the abdominal cavity that allows us to appreciate inflammation in patients. And we'll see that in just a second. And then aside from that, we have the patient's bladder, and we have the psoas muscles coming here, and then of course the vertebral column as well. And so this was a coronal, and then on the axial view, we'll start from the very top here. So we have the liver, we have the stomach, and again, you can appreciate that gastroesophageal junction as well. Again, important for identifying hernias. Patient with gastric contents, perfectly fine. And then you can trace the bowel, and you'd have to go kind of up and down, superior, inferior, scroll around. It can be dizzying on the video, but on your own time, feel free to do that and see if you can trace the bowel, just to get familiar with the anatomy. See the mesentery, the small bowel, and we know it's small bowel as well, just given the caliber of the intestines here. And also, you can see the haustra on the colon here as well, the transverse colon that we're seeing coming across the gallbladder, the liver, and then of course the kidneys, and then we can see the arteries as well connecting to the aorta. So identify the aorta and then trace that out and go from there. And then you have the same idea for the inferior vena cava as well. And then you can see the pancreas. If we try to find it here, we go up, and then we can see the pancreas has a very distinct look. Again, kind of looks, to me, I always thought it looked like adipose tissue. If you were to do a live dissection, you can kind of get that very lumpy appearance, and that's very normal there. And so that is important. In terms of a search pattern, for radiologists, of course, they're going to have their own methods of doing it. Everyone's unique, whether you start from going through the stomach and then work your way back up and then trace around. There's so many different ways to approach the CT abdomen. For medical students, I think it's great to focus on the key elements that you're looking for as well. Of course, you don't want to miss anything, so if you could be rather systematic in appreciating the structures, maybe look at the stomach, then look at the liver, gallbladder, and then try to trace the bowel coming from the stomach, go to the duodenum, see if there's anything else, and then go through the rectum and try to trace that up. I think that's pretty sufficient. Normally, you'll be able to see anything that stands out and striking, and then you can see the kidneys as well. And now, I think one big important note here is that a lot of times it's easy to skip looking at certain views. So typically in a hospital setting, you'll see that clinicians or whoever, the healthcare professionals, mainly focus on the axial image. the axial image provides certainly a lot of value. Certainly a lot of value, but with any type of viewpoint, it has its own limitations. And for me, I personally like to start with the coronal. I feel like it gives me a nice broad overview of what's going on in the patient, and you can identify anything that strikes out, and then really hone in on specific details and its orientation here. Especially if it were like appendicitis, for example, seeing an appendix on a coronal view might be a little difficult, but you can see here that structure is a bit more obvious perhaps just because it has that little loop, and then you can see it better versus the other perspective. So keep that in mind for when you develop your own search patterns and make sure not to miss anything. So let's go through some common pathology. For these cases, we'll go more directly into the pathology just to save some time. And again, the search pattern is very user dependent. So this is a 55-year-old female with pelvic pain. And so again, personally, I like to go through the coronal first. And so let's start from the very anterior aspect. I like to be systematic that way. So you can see the liver, you can see all the structures here, but mainly we'll be focusing our eyes down here in the lower abdominal cavity. And so one thing that you'll notice here, and this will take some time, is that you'll notice that there's a lot of hazy gray opacification here, and this is actually indicative of inflammation. This is what happens when the mesentery and the fat is otherwise angry or becoming inflamed. And so for this patient, they actually had diverticulitis. And so if we keep going, you can see all that inflammation. So that clues our eyes, okay, there's some pathology here. And what really tells us it's diverticulitis is because you can see the diverticula, right? You can see all these little outpouchings that shouldn't be there. Now, what is tricky somewhat about identifying diverticular disease is the fact that sometimes it kind of looks like the normal bowel, right? If you think about how some of the bowel has air inside, right, that's normal. But then you can see that it doesn't look entirely the same. They're on the external aspects of the intestine there. And now let's give another viewpoint. Let's look at the axial view. And so if we look here, again, you can see all that inflammation right here, right? And then fecal matter, that's fine. And then you can see, again, I appreciate these little dark circles. And those are the little outpouchings coming from the diverticular disease. Alrighty, and then you can see that there. So that's a pretty easy thing to identify as a medical student. Just looking at the colon, and sometimes you'll see these, but you won't see the inflammation, and that's the clue in for diverticulosis, right? Diverticulosis is the absence of the inflammation, so you're not going to see this gray hazy opacification. And to me, I like to think of diverticulosis. It kind of looks like corn on the cob, right? If you think about these small areas here, these being the outpouchings, kind of looks somewhat similar to the diverticular disease. And that's kind of how I like to think of it. You'll see it a couple times, and then you'll start to realize it's pretty easy to identify. So that's a good one there. All right, so for this patient, again, I like to look at the coronal view. And so immediately we can see there's something going on here in the stomach area. And so there's this giant structure here, right? And so if you were to think about, again, how I mentioned the perspectives of viewpoints, you could appreciate that this is a hernia, right? A little bias, or if you're very comfortable, you can easily call that, the hernia there. But if you want to see it from a different angle, you can follow the esophagus here, and then you can see the stomach here, and then as it crosses the gastroesophageal junction, right? So this is why the axial is very useful, and in all views are very useful in terms of giving you another angle, and that's what this case ends up being. This ended up being a hernia, hiatal hernia, and so you can appreciate the stomach here as well. And this is very common to see. Now, in terms of the severity, this patient has, pretty much the whole stomach in the pretty much thoracic cavity, it looks like, right? But it tends to be a little bit of the stomach coming through the diaphragm there, and not so exaggerated as in this case, but of course, you wouldn't want to miss it. And then in terms of a sagittal view, the sagittal being the side here, right, you can again appreciate just how much this is protruding into the thoracic cavity. It's almost aligned with the ventricle there. So that's that. Pretty common case. So while we won't be talking about abdominal radiographs, I included this because it's somewhat obvious. So this is a 70-year-old female, 4 days of constipation and abdominal distension. And then they had some history of abdominal surgeries, which is important for the etiology of small bowel obstruction. And so this case here, the one thing you want to notice, so abdominal radiographs are rather non-specific. They don't really give you the most detailed information. But when it comes to air in the bowels or otherwise air in general, it can be helpful. And so here you can appreciate the width of the intestines here and the fact they look like giant worms or other snakes or anything else you want to call it is a clue into the disease. And so you can see that. And so that would certainly warrant a CT image. So for a small bowel obstruction, so you can see these air fluid levels, right? And they're not, in this case, yes, they're pathologic, but sometimes you can see them in normal healthy patients, right? Just due to gravity, if you have air going up and then the fluid resting down as the patient lays supine or flat on their back, it is expected. However, what separates a small bowel obstruction from any other kind of normal state or pathologic state, I suppose, is the fact that it's fairly diffuse, right? If you were to keep scrolling, you see there's just a lot of air fluid levels. It's pretty diffuse, right? You can keep going, and then we go back more inferiorly. We can see here, keep seeing it, and then the bowels themselves maybe look a little bit more thickened. And then again, it looks like there's a lot. And if you compare it to the normal anatomy, we saw that the intestines were definitely there and occupying space, but they were a bit more subtle in their appearance. And so in this patient, we can go to the next slide here and see that there's actually the transition point. And so for radiology, you certainly will want to identify that if you can. And then for a medical student, just know that this is the pathology of a small bowel obstruction. And what you'll see, which is pretty useful to think about and know, is that prior to the occlusion, there'll be backing up of fluid and contents and air, right? Again, we consume air as we eat, drink, whatever the case may be. But after that transition point, if they had a coronal, perhaps it might be a little useful. But if you, after the transition point, there's not as much air or contents, right? Because it would have been expelled through the rectum or it's not having a chance to pass through. And that's why here it's actually hard to appreciate some of the large bowel. And you can tell it's very, very minimal in its caliber compared to how it normally is. And that's because of the idea it's, quote unquote, artificially deflated just because there's nothing going through it. And so that's important clue in again for that disease. In terms of the USMLE exams, certainly identifying the SBO, small bowel obstruction, from the radiograph is important, and then CT image, it may have it, maybe rarely, but they'll definitely focus on what caused it or what do you want to do next. Alrighty, so let's look at this patient here. So this patient is coming in for a 60-year-old male workup of abdominal pain and jaundice. So of course, jaundice automatically focuses your attention to the right upper quadrant naturally. And so this patient ended up having cholecystolithiasis. So there's a gallstone obstructing the common bile duct. And so as we look, focus our attention on the liver here, we can see that the patient still has a gallbladder. And if we keep looking at it, we see there's actually hyperdensities, hyper attenuating little structures within the gallbladder. And those are going to be the gallstones. Okay, so now as we keep going down, or more posterior, I should say, we can actually see the bile duct is fairly enlarged. I mean, it takes up almost my whole cursor about. And typically it's pretty difficult to appreciate. And even in pathologic states, for the cases I had seen, they were never of this caliber. So this is pretty severe in terms of the obstruction. But just know that this is what it would look like in the most, kind of severe sense, and allows you to appreciate the image a bit better. And you can actually see the gallstones and where they're obstructing, right? And so if we go to a axial view, let's see, we can see it here. And then so we're scrolling more inferiorly. We see the gallstones again, and then we're connects, come in here, and then again we can appreciate how dense the gallstone is and how dilated the the duct is, the common bile duct here. Alrighty, so that is cholelithiasis, right, because of gallstones in the gallbladder, and then choledocholithiasis because there is an obstruction. Our next case here, so again, I'm going to look at the coronal first. So this next case is a 35-year-old male, acute onset of severe epigastric pain radiating to the back. So that's a pretty classic presentation for pancreatitis. So as we look here, we can see the pancreas, right? It's a bit more difficult to appreciate, and you may be noticing that too. And it's because there's this gray density within the abdomen, kind of surrounding the structures here, right? And so this is fluid, peripancreatic fluid, and this is due to the inflammation brought on by pancreatitis. Now you compare this to the neuromesentery and abdominal cavity, and you can tell that there's certainly something off. Again, I'll always say that this is the key to understanding radiology, is knowing the normal versus the abnormal. And so if we go to an axial view, let's see with contrast, you can actually see all that swelling and, of course, the inflammation and fluid accumulation as well. And you'll notice here something might be striking to you, and this is something I kind of found out later in my learning journey, that this fluid seems to be around the kidneys but not touching the kidneys, right? And that's because the kidneys have their own space, the perirenal space. So they have their own space, just like there's a posterior peritoneum and other retroperitoneum, I should say, and other cavities within the abdomen. The kidneys have their own space as well, so they're somewhat shielded from this, which is, I suppose, nice. And there's just a normal anatomy and knowing that they have their own space. And so let's see here if this would be useful to show. Okay, let's see here. And so you can see I want to show this without the contrast here, right? It's a little bit difficult to appreciate the structures. Everything kind of seems like a gray mess. It's not too exciting in terms of appreciating the anatomy. But then once we give some contrast, this will be arterial phase, so perhaps not the greatest example, but you can certainly see the structures a bit better. The spleen's more visible, the vasculature within the liver, the kidneys are certainly more visible, the intestines kind of pop out a bit better. And that's the perks of utilizing contrast. Alrighty, so this case here, we have a 75-year-old male with back pain, some pain in their lower back here. And this is typical of nephrolithiasis or kidney stones, renal calculus, all synonymous here. So as we see here, this is a non-contrast study, which is appropriate. When you're looking for kidney stones, you don't want to use contrast because the hyperdensity or the hyper attenuating, I should say, kidneys and the contrast itself certainly make it more difficult to appreciate the kidney stones. And so you can see here, you can see the kidneys, but you can't really appreciate the cortex and the medullae as well, right? And that, again, that's just because of the contrast. But you certainly can see here, there's something around the kidneys. They don't look too happy, right? There's something, whether it's fluid accumulation or whatnot. And then as you go down, you can see that hyperdensity there. And that's going to be your kidney stone. And then we look at the right kidney, and we don't see any kidney stones there. Now, you may be questioning, what is this here? These hyperdensities along the structure, which we identified earlier as the aorta, right? So these are calcifications. So this is indicative of atherosclerosis, and you can see that pretty commonly. That's pretty common to see. And let's look at this from the axial perspective. And so there's your kidney stone. Go more inferior, not really appreciating much else. And then as we go more superior, following the ureter here, see the kidney. And then you can actually see here as well, there's something coming off the kidney. And we'll talk about that later, the differential of a cyst, abscess, or even neoplasm. Right, and then you can see the rest of the contents. So kidney stones are certainly common. And this is another case of kidney stones in an 80-year-old male. But in this case, you can see the left kidney here. And there's a lot of this hypoattenuating aspect of the kidney. And this ended up being hydronephrosis. And so the kidney is pretty much swelling because of the large kidney stone here. This is certainly going to need some type of intervention. And then as we go more posterior, we're looking for more kidney stones. Now let's jump our eyes to the right side. Not seeing any hyperdense structures, right? No hyperdense structures here. And then you can try to trace, look at that. Look at that ureter right there. That's pretty nice. That's a very good view. And then you can go from there. All right, so that's what a kidney stone can look like in its most severe form. You get the hydronephrosis, some obstruction. And then in contrary to the other case that we saw of the kidney stone, very, rather mild, we'll say, just in terms of the lack of obstruction, right? And so you can see here, and this looks like the contrast, and that's why, again, it can be a little difficult when you order contrast for kidney stones. Alrighty, let's see. This case here, we have a 35-year-old male, back pain for 3 days, and not too much else to comment on there. So let's see what we have. So let's start from the very top here. And so we'll keep going, and we'll see the kidneys again. And then I just want to show another example of the fact that patient has contrast, which is fine, I suppose, but you can appreciate here that the ureter is certainly dilated. This is also known as hydroureter. And then you can see the obstruction here. So it took us a little while to find, but you certainly see the calcification. Now, if you were to look at it from the non-contrast axial, which would be the ideal image, then we can scroll inferiorly, and then we can see the same idea here. The hydroureter, the dilation of the renal pelvis, and you can see the obstruction. And shortly after the obstruction, there is no dilation, right? It's everything prior to the obstruction. And again, that's another case of how a kidney stone can present. Alrighty, so for this case, look at the coronal. We have a 70-year-old female, sepsis of unknown origin, treated in the ICU, and they're trying to identify the source of infection. Alrighty, so one thing that stands out is certainly the kidney, right? So we're looking around the kidney, and typically, remember, we're looking for the mesentery being very dark, right? I know the image in itself is a bit more brighter than usual. That's certainly fair to say. But you can definitely tell there's something around the kidney here. And this is going to be inflammation. And this person ended up developing or had pyelonephritis. And so this is an example of seeing, again, the inflammation around all that fatty tissue gives us what we call fat stranding. That's the key word that radiologists will say. Fat stranding from the all that information. And if we look here in the axial, and again, you can see the same idea. And you can see the kidney itself also looks abnormal in comparison to its contralateral companion. And then you'll see here the ureter as well is also inflamed, and that's part of the sequelae of pyelonephritis. So in terms of boarding exams, not going to see that much in terms of an imaging standpoint, but you certainly need to know if imaging would be warranted, which is fair to order, of course, and you can go from there. Alrighty, let's see this patient here. So we'll look at a case of pyelonephritis, right? So now this is going to be a case of a 75-year-old male or female with groin pain and then some air in the urine, given the bubble appearance, and then they also have diabetes. So anytime you see a patient with diabetes, you certainly want to think about infections and pretty much any kind of severity. So patients with diabetes are somewhat immunocompromised, right? And so it's common that they get a more worse presentation. And certainly in this patient, aside from all that air in the leg there, we're not going to talk about that one, but certainly they have what we call emphysematous pyelonephritis. So there's actually air accumulating within the kidneys themselves due to infection. And that is something I've seen surprisingly multiple times in a clinical rotation as a medical student. And so it's not entirely uncommon, and it's certainly a bit more easier to appreciate given the fact that there's air. And so if let's look at a sagittal. We haven't seen a sagittal in a while. And so we can see here from the infection. And what we're seeing, all these hyperdensities are likely to be renal calculi as well, right? Not too many things can cause calcifications within the kidney like that. And so they show here, this is a lung window. So we'll do a little hint, a little hint into a case that's to be coming up. If you have if you pull up a lung window and you're concerned for free air within the abdomen, the lung window certainly makes it easier to appreciate. In this case, the patient did not have that. Let's see what this ends up being. I don't know if there's anything here to show. All right, there's not. So that was emphysematous pyelonephritis, and this is another case of that. And you can see here as well, again, that air within the kidneys, and then the staghorn calculus, again, being the etiology of this. So it tends to be a certain predominance in terms of the organisms that are involved. And this patient looks like it's more unilateral compared to other patient had it bilateral, which is a bit crazy to think about. And then this patient has 55-year-old female, flank pain and mild fever. Perhaps they don't have a history of diabetes, but nonetheless, they certainly developed a pretty severe infection of pyelonephritis. You can appreciate that as well. And that the air within the kidneys, again, abnormal, of course. All right, so this case is a little bit different. We have a 70-year-old female left upper quadrant pain 1 day post colonoscopy with associated presyncopal episodes. So we know that images are a bit bigger. So we know this patient had a recent procedure, right? So it certainly plays a role in what we're going to be seeing and what we are going to be expecting. And so if we were just to stop it here, right? There's certainly a few things that stand out. We can see a mesenteric gray, that's fine, but we also see that there's a lot of gray, right? All this gray opacification, and then around the spleen here as well, you can see that there's a lot of fluid, and we know it's fluid whether ascites, blood, or whatnot. We can certainly tell just given the density of its appearance. In this case, it ended up being blood just from the patient's postoperative history here. And so we go to the next case. Let's see. Again, let's scroll through the coronal here. I think it ends up being the same idea. And then you can see some contrast. It gets into a bit more fancier in terms of how you determine the how you detect blood leaking from the organs here. And so nonetheless, this is a laceration that the patient ended up having. And you can see just how profuse all the fluid is from the case. And that's something to appreciate. So I think the takeaway from this, certainly not on the USMLE exams, but clinically speaking, if you do see a bunch of gray within the abdomen, which is supposed to be black, then you would definitely want to be thinking about if there's fluid accumulation. And speaking of fluid accumulation, we'll have a 14-year-old male, progressive abdominal distension and elevated liver enzymes. So this male here has cirrhosis. And the patient has cirrhosis, and we can tell because you can see the lumpy nature of the liver here, right? It looks atrophied. It's very small. And while you can measure it out and get into more determining objective metrics, you certainly can just tell visually. And then given the patient's clinical history, we also have some fluid accumulation. And right, you can tell the difference between this fluid accumulation versus the blood in the previous patient, right? This is all acidic fluid. This is all ascites here, all within the abdominal cavity. Now, if we were to look at it let's look at it from this perspective of an axial view. Again, you can see all of that fluid, and then you can see the oral contrast that the patient had. Looking at a sagittal, again, you can just see, sometimes you may see abdominal distension, right? You want to use all the context clues that you can. So there's abdominal distension, see anything else with their spine in terms of positioning or the liver here, and then go from there. So that's cirrhosis. That's very common, of course, to see within the hospital setting. Alrighty, let's see. Let's just look at the X-ray here. So we have a patient here. I think I had shown this before on another image, but nonetheless, so this patient here, let's just look at the CT image. So for the CT image, let's look at the coronal view. That's always my favorite. And just I'll just very briefly say that this patient has um, ended up having free air within the abdomen. And just given they were concerned, of course, from the symptoms. And so from a coronal perspective, you can see all the bowel, and certainly looks like there's a lot going on. But nonetheless, you don't really see anything maybe crazy in terms of free air, right? So the coronal view is certainly not a good view for free air, certainly not a good view. And so if you go in superior and then now we're going inferiorly, the way to appreciate free air is you'll see it again rise to the anterior aspect of the abdomen. And so this is all free air. That's free air there. And then as we keep going more inferiorly, we don't really see too much more. But this patient certainly had pneumoperitoneum, and we can appreciate that from the axial view here. And if you have the opportunity, you would certainly want to put on the lung window because it allows you to isolate the structure, the soft tissue structures, and really focus on the air accumulating. And so we'll see another case of the same idea. So for this chest radiograph, you can see this right diaphragm is not only elevated, but there seems to be an increased lucency just inferior to it, indicative of pneumoperitoneum. And then just more air within the abdomen here, more so within the structures, the viscera. And then now let's look at the axial view. And again, so now you saw the very mild form of pneumoperitoneum. Here's a very severe form where you can certainly see all that air accumulating, right? Now let's look at it from the perspective of a lung window and look how much easier it is to appreciate that. Of course, you want to make sure you're not mistaking the free air for anything within the bowel, but certainly you can appreciate the free air from the lung window. So this is the importance of windowing when you're looking at it versus windowing and even your views in terms of coronal and axial. Perhaps you can see the free air here, right, from the coronal. Again, I just don't think it's a very sensitive view for looking at free air within the abdomen. Of course, the axial view is going to be preferred. Alrighty, so now we have another patient here. So this patient is a 75-year-old male, non-specific abdominal pain, abdominal ultrasound revealed aortic aneurysm. And certainly here it is, right? So we can see the aneurysm. We can see there was contrast given, and it allows you to really appreciate the abdominal aortic aneurysm here. As we go more inferiorly, we can see here our nice aneurysm. And so this is what would be called fusiform aneurysm. So when the aneurysm is very rounded like this, and it's in line with pretty much the aorta here, that's fusiform. Where if it was saccular, it'd be protruding kind of in one direction and then still have somewhat of a normal wall on the other side. And so that's a little bit of nomenclature, but nonetheless, you can certainly appreciate this. And you would want to measure this and see kind of where they're at in terms of sizing, of as that of course leads to the indication for surgery, and that is something that is on the boarding exams and seems to present pretty often. Knowing when a patient has an abdominal aortic aneurysm, that you need to monitor it, and then if it's growing at a certain rate, that certainly is important to know. Alright, so now we're gonna get into some of a little bit of a differential when it comes to renal masses. And so this is a case of a patient having renal cysts. So if you were to see this, it certainly looks crazy, right? The fact that this is just a big pocket of something within the kidney is certainly crazy to think about, and it's pretty huge. But it's important to know by later age, into the older age, it's very, very common. It's more common than not, almost, to have renal cysts. And typically you do nothing about them, except of course you monitor them and you want to make sure they're not neoplastic, of course, in terms of any malignancy. But otherwise you can live perfectly fine with these renal cysts. And you can see that they're coming kind of off here. And let's look at the axial view. And then again, you can really appreciate their well circumscribed appearance. And so for the differential here, and to spoil the next few cases, right? So there's a renal cyst, abscess, and then any kind of malignancy. And you'll certainly see from this perspective how much different it looks in comparison to a renal abscess. So again, for a renal abscess, let's think about what you might expect. And certainly you'd be expecting inflammation, right? So you can see here, the abscess has a well circumscribed wall around it as well. It's kind of within the parenchyma here. And then as you keep going, you can see kind of that fat stranding again. It's a super important clue in for CT imaging. In comparison to the other side, the other kidney is just doing just fine, nothing surrounding it, but this side certainly has some fat stranding surrounding it. And it aligns with the patient's history. 50-year-old female, middle-aged fever, with fever, and abdominal pain diagnosed with prior ultrasound suggested renal abscess. So they had an ultrasound first, and then they grabbed the CT image. And then for our last case here, there's a bunch of ultrasounds I'm not going to cover. Let's see here. That's that, and I think this was the resolution. Okay. So let's start with the contrasted study. So certainly if you're a medical student, this is not something that you need to diagnose or even know in terms of boarding exams. But what is important to note is that how similar the diseases do appear. So you can see some renal cysts, but what is different about this here is that this portion coming off, while looking like a cyst, this isn't the right density, right? It looks like they're renal medulla. And then we see here, this is definitely darker. And then we come in here, there's something going on within the renal pelvis as well, right? So there's certainly something interesting to comment on. And then if we looked at the axial view, let's find our kidneys here, go up. And then you can see the cysts. You can see something a little bit more. I mean, this doesn't look right. It will look maybe a little somewhat lobulated. I don't know, it's got like soft tissue density. This doesn't look right. And then you keep going, and there's something else here, right? And this is certainly concerning. So overall, the patient went on to have a biopsy, and they were found to have a cancer of both the ureter here, the renal pelvis, and the renal parenchyma, the renal cortex there. And so you can see here some of the measurements that they were able to take, just highlighting the same ideas that were of great concern. And this is certainly important for surgical management. But that's all we have for today. Hopefully you found the video instructive. Feel free to explore Radiopaedia and the playlist down below. You can scroll the cases yourself or even go find more just to review. But otherwise, that's all I have for today, and thanks for watching.